Okay, we again want to start relatively on time, so I am just going to start, and I want to welcome everybody to the webinar on the ripple effect of alcohol and substance use disorder, how families cope, presented by Dr. Jeff Fortgang, and we're really pleased that you could join us today. My name is Amy Levine. I'm the Director of Programs and Volunteers, and I'm going to be your host. And for those who are joining us for the first time or are unfamiliar with Lawyers Concerned for Lawyers, we are a nonprofit organization serving the Massachusetts legal community with mental health and substance misuse challenges. We offer one-on-one consultations with licensed clinicians and peer support groups, as well as customized programming. We also do one-on-one consults on law office practice management. You'll have the opportunity to ask questions at the end of the presentation. You can use the chat or the question and answer function. And as mentioned, our presenter is Dr. Jeff Fortgang. He is a clinical psychologist and alcohol and drug counselor with extensive experience in both inpatient and outpatient settings. He received his undergraduate degree from Yale University and holds a Ph.D. from Adelphi University. He was previously an instructor of psychology at Harvard Medical School, and he has dedicated over 25 years to LCL alongside maintaining his own practice. And without further ado, I'm going to hand it over to Dr. Fortgang.
Thank you, Amy. Excuse me. So we're going to do kind of an overview today of concepts that arose in the addiction treatment field related to the role of and impact on families in cases of alcoholism and addiction. And let me share my screen. So this is an attempt to capture some of the common patterns and concepts that have been applied in this field. The heyday of this kind of work and thinking was about 40 years ago. I was already in the field at that time. So let's go to the next slide. So part of the notion is that of a family system. You don't hear about this approach as much as you did years ago, except as it's been revamped for internal family systems. But a family system implies that a family, just like a work organization, is a system, and that changes in the behavior of any family member have an effect on the entire family. And for example, as one person becomes less capable or predictable, other family members compensate. A good metaphor for understanding and picturing this is a bunch of people on a sailboat trying to keep it afloat. And if the weight shifts to one side, some people will move to the other side to stabilize the boat. The objective is to keep it afloat. In addition, on that boat, people tend to acquire certain roles. So someone is steering, someone trims the sails, someone navigates, etc. So three major ideas related to family systems as applied to addiction were given names in the treatment world of addiction that flourished in the 1970s and 80s. This was a time when there were all of a sudden a lot of alcohol rehabs, and insurance was still covering them. The managed care hadn't arrived yet, and it was a big new field that was very profitable for some corporations, So there was a kind of explosion in inpatient addiction treatment. And with that was exposure of clinicians to the families of the identified patients who were coming in. And they started to observe and think about some of these patterns. Not that that was brand new, but it was happening on a larger scale. These kinds of programs, both rehabs and the family component, declined starting in the mid to latter 80s, when a few things happened. The research began to turn more toward medicalized and brain-oriented information about addiction. The trauma movement began to grow and subsumed some of this, especially involving children of alcoholics. And managed care came in and shut down a lot of rehabs. They didn't shut them down, they stopped paying for them, so that a lot of them folded, and it was no longer a growth field. At any rate, that's all historical background. Let's talk about some of these concepts. So people refer a lot to codependency. It seems like no two people mean exactly the same thing by it. There is no official definition of codependency. It is not in the psychiatric diagnostic manual. But here's where it actually came from. An earlier term that emerged by the late 1970s was co-alcoholic, reflecting recognition of the role that family members, especially the spouse or partner, played in perpetuating the dysfunction as the disorder progresses. So it was, and typically people thought of the husband and father as the alcoholic. And there are still, I think, more male alcoholics, but women have done a great job of catching up. And the wife was thought of as the co-alcoholic in most of the writing on this. With as the rehab movement was proliferating, other drugs were coming into the picture as well. And so rehabs didn't want the treatment to be conceptualized as only for alcoholism. So they started to adopt the term chemical dependency, which you don't hear that much anymore, but that was very much in at that time. So the term co-alcoholic became codependent. So that was the codependency is related to dependency on substances. So as the alcoholic or addict's illness progresses, in an effort to maintain equilibrium and survival in the family members, particularly the spouse or partner, often gradually take on a sense of responsibility for the behavior and well-being of the person whose life more and more is revolving around their substance. So this is a kind of a natural process. It would also happen if a family member has various other illnesses, like what that person can't seem to handle anymore, others start to move in. So this is phrased in the voice of the partner. As your ability to behave responsibly wanes, I, your spouse or partner, step up and take on your responsibilities. I pay the bills you used to pay. I drive the kids everywhere so they won't be endangered by your driving. I choreograph interactions around the house and sometimes in other settings to avoid your getting upset and angry, because your mood and behavior have become much less predictable or stable. So this is codependency as defined in relation to an addiction. Also, I manufacture excuses to those who rely on you at work. And I try to, and this was back in the days, by the way, where there were still a lot of families that were one-income families. And if the alcoholic or addict was the person producing the income, it was in the interest of the whole family to try to maintain that income. So I manufacture excuses to those who rely on you at work to try to preserve your income. For example, when you're in no shape on Monday morning to go to work, I call up your boss and say that you're in terrible pain, you threw your back out. And also to our friends and neighbors to pretend that things are okay. So this is where there's increasing chaos in the family, but the family makes an effort to cover it up. I admonish the kids not to say anything that might ruffle your feathers. We want to keep you as stable as possible. I also probably admonish the kids not to tell anybody else about what's happening in the house. So I'm saying that there's some overlap here with what lawyers are familiar with doing, which is trying to seem like they know what's happening and they're in control at all times. I've talked about that in other settings, about part of lawyer culture that makes it tougher to become aware of and honest about one's emotional state. By going to these lengths, not confronting the addiction, helping evade the natural consequences of the behavior, such as your job is in jeopardy when you don't show up, I make it possible for the addiction to progress. And this is what we mean by enabling. So there's an overlap between codependency and enabling. At the same time, I gradually come to ignore my own needs, responsibilities, and well-being. My focus is on feeling responsible for you, not for myself. So I may neglect my health. I may make sure that you're trying to get you treatment that you need, but not getting treatment I need. I may not be getting enough sleep. I may not be taking care of myself because my mind is entirely on taking care of you. On the other hand, I may become quite comfortable in my role as the one who now controls much of what goes on in the family. I'm running the finances. I'm deciding what we do. I'm the CEO of the family. Over time, the term codependency has been generalized to relationships that are not limited to those with addiction. The key concept, however, as I see it, and again, different people describe it differently, is of experiencing oneself as overly responsible for another person, which is really hard to do. It's very hard to be responsible for an adult who's not you. And tending to ignore responsibility for oneself. People commonly use the term codependency when they mean simple dependency. So there's an overlap, but they're not the same thing. Dependency refers to, and dependent personality, which is an actual diagnosis, refers to the behavior and attitude of the person who is overly reliant on others and on being validated by others and having other people do things for them. Codependency refers to the person who assumes too much responsibility for another person. And that becomes a dyadic relationship, but also a characteristic of the person who's now configured to take that role. So that's what I have to say on codependency. And if you have any thoughts on that, jot them down and we'll bring them up later. So another field that developed around the late 70s was looking at children of alcoholics and ACOAs, or adult children of alcoholics who had grown up in alcoholic family systems. This was actually the first dissertation topic that I proposed. And I could have been a contender, but my dissertation committee didn't like the idea of a retrospective correlational study. So let's talk about what you would expect in a healthy family. This is a picture from the TV show Father Knows Best. Most of you are too young to have seen it at the time, but ironically, the two males in this picture both had addiction problems in real life. Robert Young, who was the father, wrestled with alcoholism his whole life. Billy Gray, who was the young man, teenager, wrestled with opioid addiction. That's just a side note. So in a healthy family, which this appeared to be, and I know that as a kid, I was looking at this show and thinking, this is what my family should be like. Parents are generally loving. Parents are relatively consistent and predictable. There's an ongoing sense of safety and that the adults are capably in charge. And communication is relatively open and honest, both within the family and with others. Now, when there's active parental alcoholism or addiction or other conditions such as bipolar disorder, the parental demeanor and behavior and the home environment can be unpredictable and sometimes can be neglective or abusive. One of the things that children talk about, or that adults talk about remembering, is the thought of if mother is the alcoholic or addict, which mommy is home today? Sometimes she's loving, sometimes she's punitive and angry, etc. And another kind of thing that one hears a lot in this family is don't say anything that might get dad angry. And there's the feeling among the children of walking on eggshells and living in fear of parental anger or other unstable behavior. So that's not an optimal situation in which to grow up. When parents are not reliably in control, children may feel the burden of doing whatever they can to maintain control and minimize abuse or fear. As you perhaps know, young children tend to feel that they have been the cause of anything that's going wrong in the family. But that general sense of over-responsibility on the part of children, because the parents aren't completely fulfilling their role, continues over time. And so the goal is to try to keep things under control and make things as safe as possible. Now, I say in the box on the right, it's important not to overgeneralize about this. Every family is different. And these effects vary in severity and pervasiveness from family to family and are affected by factors such as the duration of the dysfunction, for how many years are things in that shape, the age of the children, obviously, or maybe not obviously, if the child has grown up in a better functioning household until they're 16, it's different from if it was that way from early on. And also whether the family gets outside help. And unfortunately, in many families with active addiction or alcoholism, they avoid getting outside help. The idea often is to try to keep a lid on things. By the way, it is a little better now that there are two-income households and the need to maintain one person's income and to try to deny the alcoholism or addiction is not as strong as it was. But the point here, by the way, is not to blame the parents. Their behavior stems from an illness. They're not doing this intentionally. So children and families with alcoholism and addiction or addiction tend to experience some of these things: shame and the need for secrecy, isolation. For example, in general, it's not a good idea to bring many other visitors into the household where things might be unpredictable and embarrassing. And also isolation in terms of how much information is shared with non-family members. The children tending to feel responsible, wondering what they could do to make things right. When this kind of thing is going on at home, of course, there's difficulty concentrating in school. And on the other hand, or in addition, school may become a refuge and a way to stay out of the house for as long as possible. So there are three major thinkers and writers whose work became well known around the late 70s, early 80s with regard to children of alcoholics. One was Claudia Black. And from her work, one of the main things that took hold was the idea of the rules of the dysfunctional family. Don't talk, don't trust, don't feel. So the rules tend to be, we don't want to acknowledge what's really going on. We don't want to talk about anything real. The children learn not to trust because the parents are unreliable. Broken promises, oh, I'll definitely be there for your game or your play, or I'll do it next time, or this will never happen again, things like that from the parents. Those promises tend to be broken. It's the idea that secrets must be kept and that you can't just assume that life from day to day is going to be safe. And in terms of feelings, what is communicated to the kids is that if you express your feelings, that can lead to angry reactions. It can be ignored. It can upset the apple cart. And so emotions are to be stifled or denied. And one of the things that was noticed early on in treating adults from alcoholic families was that they had difficulty naming the feelings that they had, because at ages where they would have learned to identify their feelings, that didn't happen. So children of alcoholics tend to take on different roles, just as we talked about on the sailboat. This is unconscious in that they don't know they're doing it, but in their shared efforts to keep the family afloat. So here we come up with one of the other names that became well known at the time, Sharon Wegscheider Cruz. She was Wegscheider and she married a guy named Cruz. And one way of capturing these roles and adaptations is through the names that she gave to these family roles. So the first one is the family hero, who is often, but not always, the oldest. And this child tends to be overly responsible, stressed, an achiever, and the achievement serves the purpose of bringing esteem to the family. It feels like, hey, we're doing okay because look at what our kid is achieving. This child can grow up to become a workaholic who may tend to put an overemphasis on control. Another role in the family is that of scapegoat. So this is the child who acts out and gets in trouble. And it was postulated that the purpose of this is to distract from the addiction and to be blamed and rejected by the family. So the family, in their effort to deny the real and central problem, can point the finger at this child. He's the cause of our problems in the family. So in that sense, he's doing a service, and he's taking on this role because it helps the family, even though he's not aware of that. It is most often a boy, but not always. Another role among the children in an alcoholic family is called mascot. This is the child who relieves the pressure through humor, and is typically a class clown. Gives the message that nothing is really important or to be taken seriously, and thereby deflects from worrisome situations. So many people who are professional comedians probably had this in their background. And finally, the final role that was named by Sharon Werkscheider Cruz is the lost child. So how this child helps out the family is by just not making any waves, being quiet, largely unnoticed. The child avoids drawing attention and gets into solitary activities like reading. These days, it might be the internet. There was no internet when she was writing about these roles, and into fantasy. And might become a writer later on. So all of these roles are intended to help the family survive. They have obvious drawbacks as a person grows up. And the third big name in the adult children of alcoholics movement was Janet Voititz. And she worked with adults, and she thought that she saw 13 characteristics that adult children of alcoholics have. So there are problems with this list, and yet they do capture something. Problems are, it's hard to find anybody who doesn't have some of these characteristics. And secondly, it's hard to find anyone who has all of them. Really, there's a lot of individual variation. But let's read through them. ACOAs guess at what normal behavior is. So that you can imagine, and I think that is often the case. If you grew up in a family in which you're kind of faking it and things are unpredictable all the time, you might not feel like you have a firm grasp on what normal behavior is or normal feelings. ACOAs have difficulty following a project through from beginning to end. These days, I think we would associate that more with ADHD. I haven't really noticed that being particularly true for ACOAs, but it may often be. ACOAs lie when it would be just as easy to tell the truth. So in my view, what this is, it's not some form of sociopathy where someone wants to mislead. The kind of lying that people do who were raised in alcoholic families is related to not wanting to rock the boat and to keep everything safe. So it's lying to not get anybody angry or to ruffle any feathers. So an ACOA, for example, might be more likely to make up a story about why they didn't show up for something or why the assignment isn't done, rather than tell the truth. ACOAs judge themselves without mercy. That is probably true as a generalization, that they're more, that their self-esteem or their self-evaluation is more harsh. ACOAs have difficulty having fun. This would, I think, be particularly true of those who had the family hero role. And let me back up and say, not every family has 4 children. So sometimes you have all the roles rolled into 1 or 2 children. And of course, if there are more than 4, these things get distributed differently. But as a rule, children from alcoholic families have a greater need for a sense of control, things being under control, and that can get in the way of having fun. And similarly can cause someone to take themselves very seriously, as listed here in number 6. ACOAs have difficulty with intimate relationships. To the extent that that's true, it might have to do with not having had healthy relationships modeled for them. ACOAs overreact to changes over which they have no control. Yes, as a generalization, they like things to be under control. However, they're also pretty good at dealing with emergencies because they've had a lot of experience doing that. ACOAs constant, and by the way, you'll find a high proportion, higher than population proportion of ACOAs among all helping professions. ACOAs constantly seek approval and affirmation. I think that is often true, not having received the kind of approval and affirmation that they would ideally have internalized as kids. ACOAs usually feel that they are different from other people. Probably true. Certainly not true of every, nothing here is true of every adult from an alcoholic family. Super responsible or super irresponsible, that may have something to do with which role they had in the family. ACOAs are extremely loyal, even in the face of evidence that the loyalty is undeserved. I do think that I've seen that, for example, where that comes up is in work situations where the level of loyalty to the boss or the organization may be disproportionate to the loyalty of the organization to the person. ACOAs are impulsive, not seriously considering alternatives, consequences leading to confusion, self-loathing. She really went to town on this one, and excessive amounts of energy cleaning up the mess. Some ACOAs are impulsive. I don't know that I actually have seen that in my own work. And by the way, during the heyday of ACOA talk, I did run a number of groups, both inpatient and outpatient, for adult children of alcoholics. So now we're moving on to another concept that was part of the family perspective with relation to addictions that also arose in the late 70s and 80s, which was the intervention. So, and I say from the Johnson model to the Arise model, and I'll speak very briefly about what I mean by that later, but the general, so up until the intervention, that concept, the widespread idea, which had great validity, was that alcoholics are not going to wake up one day and say, gee, I'm drinking too much. I really ought to do something about that. So the idea was that they had to hit bottom. Now, there always were some people who hit higher bottoms than others. And sort of how bad do things have to get for you to feel like, as addicted as I am, I have to do whatever it takes to change this. So for one person, hitting bottom might be only losing a job. for example. For another person, it might be losing job and family and health and home. So the idea of the intervention was, maybe if we get the family involved, a person doesn't have to hit such a bottom. So the first step in an intervention then, which is organized by a family member, typically, sometimes it was by an employer, is education and preparation of the concerned significant others. So typically a therapist or so-called interventionist would meet with everybody in the family other than the alcohol. I'm just going to say alcoholic, but it could be addict. Other than the alcoholic, to help them understand how the illness works and progresses, and also to begin preparing and rehearsing. And that can happen in a session, or it can happen in a number of sessions. And there certainly have been families who undertook this without a professional, and sometimes they probably succeeded, but it's not something that I would recommend. The essential message once the intervention session actually occurs, and that's especially in the Johnson model, that is, a date is set, and this is when we're going to do the intervention. And I'm sure you've all seen depictions of interventions. So the alcoholic is told, we've gathered here, we want you to listen to what we have to say. And each person's message, as people take turns and typically read what they want to say, is, here's what I have seen or experienced regarding your drinking and how I felt about it. So they'll give examples of, remember that time when you yelled at me in front of my friends, or whatever it was. And I felt embarrassed. And then the second part of the statement is, here's what I really want you to do about it, which is getting into treatment. And back in the heyday, again, everybody was covered. Everyone who had insurance was covered for rehab. So treatment in addiction tended to mean rehab. And you could call up a rehab and reserve a bed so that if the intervention, they had time to think twice about it. And the third part of the statement was, and if you don't do what I want you to do, what we all want you to do about it, here's what I will change, which I'm doing for my own needs. Like, I'm not going to engage with you anymore in a certain way. I'm no longer going to provide funding that you use to feed your addiction, or whatever it might be. Sometimes it was, I'm no longer going to live with you. I'm your spouse. Sometimes I'm your adult child. I'm saying, I'm no longer going to visit you unless you're sober, or you're not going to get to see your grandchildren, or whatever. But I should say it's presented not so much in a confrontational way as in a loving way, but I just can't take this anymore, and this is what I need you to do. Now, the models of intervention have come to vary over time in how soft they are and in whether the focal person is involved earlier versus ambushed. So when I was first trained to do interventions, it was the Johnson model, and they were ambushes. So the alcoholic would not know, and the idea was that they wouldn't show up if they were invited, but they wouldn't know that it was going to happen. They would be told that they're getting together for some other reason. It's like a surprise party. And then they would suddenly find, why is everyone here? And then the person leading the intervention, which could be the therapeutic person or a family member, would explain we're here because we want to talk to you about your drinking or your drugging and how we see it and how we feel about it. And then they would go around and the alcoholic would try to get away or shift the blame to someone else or do various things, and the family would have been prepared on how to handle that. And when I was first trained about this, I was even taught to block the alcoholic's car so that they couldn't drive away. I was very uncomfortable when I first was presented with this model and told that I had to do this because it was very different from my training in my role as a therapist. It helped a lot when I realized that my patient or client was the family and not the alcoholic or addict. But the more modern models of intervention, such as the so-called ARISE model, are much gentler. They're not ambushes. And in fact, the alcoholic is invited to join in the sessions from the beginning. The other really interesting thing about it is that I've seen this a number of times when I used to do more interventions. I've done very few in the last couple of decades, is that just from preparing the family, just from the education and discussion, people, without even being intentional about it, start to behave differently and to send out different signals. And it's not rare for the alcoholic to suddenly become interested in what they can do about their alcoholism without even having been confronted. On the other hand, it's also not rare that you do a hell of an intervention and they still refuse treatment. So the other part, and the reason that you don't see nearly as many interventions anymore, again, is managed care and the change in the delivery system, so that unless you're quite wealthy, rehab may not be covered at all, and it won't be possible to reserve the bed for somebody. So that if they agree to get treatment, then you have to first start trying to arrange the treatment. And as you probably know, arranging any kind of treatment these days, finding openings, finding programs is harder than it was. Okay. So the next family-related concept related to alcoholism and addiction is Al-Anon, which was started by the wife of the guy who started AA, or who was one of the co-founders of AA. And it is a 12-step program like AA, in which the thing that can't be managed is not the alcohol, but the alcoholic. And it's a way for particularly spouses or partners to give up enabling and trying to control what they can't control. So some of the key concepts in Al-Anon, one is the 3 C's, which is a kind of acceptance. We didn't cause it, meaning the alcoholism. We can't control it, because most spouses have definitely tried to monitor the person's behavior in drinking, have found bottles around the household and emptied them into the sink, and none of that works. And we can't cure it. In other words, addiction is a disease that doesn't go away, no matter how much a loved one tries. So, then, the next major concept then is detach with love. So we don't want to hate the alcoholic. We're not blaming them for having the disease. But we also realize it's unworkable for us to try to control all that. And we need to live our own life, try to make choices and organize our days in a way that is not reactive to the alcoholism or addiction, because that's going to follow its own course, but is running our own life, and it's sort of related to getting out of the codependent stance, being responsible for ourselves, recognizing that one person can't exert control over another in an effective way. Other programs for families, there's one in this area called Learn to Cope, which I've met with some people who thought highly of that. Whoops. This is inhabited mostly by parents of opioid addicts. And it's a very difficult, tragic position to be in when your adult child is behaving in a way that really endangers their lives, derails their lives. And yet you can't have them, in many cases, living with you, getting into trouble, stealing your money, stealing your jewelry in some cases, etc. Not that that always happens. Every case is individual. But just having a child who's in active addiction, very painful. So this is not a 12-step group, but it is a group in which parents give each other support and pointers. Another program is Naranon, which is the Narcotics Anonymous counterpart to Al-Anon. So it's like Al-Anon, it's more focused on drug addiction. There are way fewer meetings, and so a lot of people go to Al-Anon instead. Very importantly, it's not to be confused with Narc-Anon, which is a so-called addiction treatment network run by the Church of Scientology, and which is, in my view, using deceptive marketing to reel people into the world of Scientology. They do, I'm sure, believe that Scientology is the answer for addiction. And finally, there are various professionally run treatment programs, and of course, there are therapists who specialize or have expertise in treating family members of alcoholics and addicts. Yes, so I think that that's all I have to say about these things. The timing worked out fairly well. And if there are any questions or comments, we have a few minutes for those. Thanks.
Well, first I want to say thank you so much, excuse me, Dr. Fortgang. This was extremely informative. I also really enjoyed the boat analogy. And it made me realize nothing in life happens in a vacuum. So any behavior, anything really is going to affect those around us. And also the emphasis that this is a disease. And but again, there is impact on those of us around us. I also want to let people know, and I know we do have some Q&A, some questions, that if somebody does want more help, you can certainly give us a call and talk to one of our clinicians if there is a loved one that you want to get a little more advice on how to handle things. So let me first go to the chat. Will the slides be available? Yes, they will. And we will send those to you. And is the PowerPoint going to be emailed? Yes, it is. So those were easy enough questions to answer. We have a comment. Thank you so much. Will you provide a replay of this? And just to let people know, if you go to our digital library, it will be there. Everything, every webinar that we do is recorded, and you can click on that. Somebody is asking, what do you think of Section 35 petitions? And then I think the follow-up maybe from the same person is, what are the pros and cons of Section 35 petition for a 33-year-old male?
So as lawyers may know even better than clinicians, Section 35 is a way that families in particular, and sometimes or drugging is imminently dangerous. And so unlike Section 12, which is a mental health related involuntary hospitalization, and that's most frequently initiated by a clinical person because somebody's mental health is such that they are an immediate physical danger to self or others. Section 35 is most often initiated by significant others. And the threshold, my understanding is, of course, if everybody who is related to or knows someone who's just actively alcoholic or addicted initiated a Section 35, there would be way too many. And if it were a case of what is it dangerous, there'd still be way too many. So it really has to be concrete, tangible, imminent danger. I think where this comes up as a question is partly with people who are currently drink and drive. And my impression is that when it actually happens, it's someone who's doing that a lot, and where the evidence that the driving is dangerous is quite obvious. Or certainly someone who, because they're drunk, is behaving in an overtly dangerous way. So what happens is you initiate the Section 35. A judge decides whether the person is going to be involuntarily incarcerated. The facilities, I think, are improving a little bit, but I think for men it may still be Bridgewater. Somebody might be able to correct me on that. For women, it was a slightly better incarcerated setting. People, I don't think I haven't been involved with a whole lot of Section 35s in my whole career, but of the people that I've met with who had them, none of them spoke highly of the experience. So, and it didn't sound like it was highly therapeutic for anyone. The only reason to do it is really to try to save a life in a short-term way. And then people will be kept for, I think, a few weeks. So some people who are listening to me may actually have more firsthand experience. Most of my experience has been with people who call me about should we do it in advance, and more often meeting with people who had had a Section 35 in their history. The best outcomes, I'll tell you this, the best outcome is when a person is liable to be Section 35 and their attorney says to the judge, how about instead of going to this unhelpful incarcerated facility, my patient will go to an actual private rehab. And that experience of being and having to stay there with judicial incentive, that I have encountered cases where that had a very positive outcome, where by the end of rehab, somebody really was motivated and began to make strides in terms of getting toward recovery. So I know other questions came in while I was talking. Were any of them information about that or?
So related, what state resources are there for treatment as an alternative to incarceration for criminal defendants who offend due to substance abuse?
This is not my expertise. There is a whole organization about courts and addiction. There are some courts that have diversion programs for addiction. That's what you want. What you want is for someone to have the motivation of, oh, now I'm in trouble, but to have the off-ramp of I can go into treatment instead and have to continue, not be able to blow off the treatment because I really have to stay there to avoid further kinds of legal punishment.
And I'll just add that I know that there are programs out there, and the courts do provide social workers who can find treatment. So the courts are aware of the need for that. And again, as Jeff mentioned, more of a diversion program. So what they can do is try to find a bed for them at a particular rehab. So that's certainly in effect. I know that there are actually some new technology, new apps that are out there. So this is interesting, where they will scour through their resources and very quickly be able to come up with a match of here's the health insurance that somebody has and here's the bed that's available. Also, that is something that we do have a referral list of therapists that do specialize in addictions. So you can certainly reach out to us as a resource, and also resources on inpatient treatment or outpatient, where we work or know actually a few that we could recommend.
I also think I've encountered in some cases attorneys who are defending clients for DUIs or other criminal activities that were related to drinking or drugging, who even while providing a zealous defense have effectively leaned on their clients to get into treatment to avoid this happening again. And I think those people are doing a real service.
Yeah. And I do think judges out there are a lot more aware of these issues, and they are trying to treat it differently. So I think there's progress being made. And so that's, I think, the positive news. We have just one more minute if there are any other questions. I know, Dr. Fortgang, this is your expertise. This was, again, really informative, and I think just helpful for those who are out there that are experiencing a loved one with any of these substance misuse challenges. And again, please use us as a resource. Go right on our website, LCLMA.org, and you can make an appointment with one of our clinicians, and again, use us as a resource in that regard. So that is it. It doesn't look like we have any additional questions, but thank you, Dr. Fortgang, for your time and sharing your expertise. Thank you, everyone, for joining us. Again, you can go to our digital library. It will be there for your viewing. I would just say give it a day or two before it shows up. And again, you will receive through email the slides as well. All right, thank you again, and we look forward to seeing you very soon. Thank you. Bye.